네, 임상 고민을 나누고
This is the case discussion to share the clinical difficulties and find the best treatment solutions. Hello, I am MC, Dr. Seong Min. We have three clinical masters with us, Dr. Son Young-hee, Dr. Kim Ki-Seong, and Professor Seong Min. Hello. Before we discuss the case, those who are watching the dental TV, on the right-hand side of the video player, there is a real-time chatting window for you to post questions to us and share comments. Let's look at the case. 79-year-old female patient, no systemic disease. At lower right posterior at number 46, implant is planned under insurance. On the CT image, the bone quality is D4, very poor. How can I get proper initial stability in this case? Is there any precautions that I need to take? So that is the story from a dentist. On the X-ray, number 46, the bone density looks very low. To avoid failure, what do I need to do? What do you think? This is a common case that I see clinically. If you look at the initial exam and the after extraction, it doesn't tell why it was extracted. The patient is a senior patient. That can occur due to perio disease and also from root planing. Therefore, when we do the extraction, we tend to be careful in doing curettage. So from the extraction stage, we need to be very careful. If we carelessly place an implant, we can face a disaster. So I'm going to introduce such cases and talk about the know-how for that. I don't want to work with that bone quality, but I want to work on that. Maybe I'm not hungry anymore. Initial stability depends on the bone quality. There are many ways to achieve the initial stability. I will talk about how using my cases. Those who are watching this, please think about how you would treat this case. If you have good idea, please share that with us in the real-time chatting window. Let's hear from our clinical master how you would address this problem. Professor Seong Min. Yes, I have prepared a case. Implant, bridge, and endo treatment. Various things are here. In 2016, at number 46, endo treatment was done, and there's post and crown. Over time, little by little, it's getting deteriorated, and the crown falls off and is removed. There is not much chance of restoration, therefore we decided to extract and place an implant. It is extracted. I don't know what that is. After endo treatment, in the radiolucent lesion, there is a radiopaque mass. I tried to remove it, but I couldn't find it. I really tried to remove it, and I don't know what that is. I thought it would be some foreign body, but I couldn't remove it. It's healed. October 30th, 2019, it was extracted after 4 months. In February 2020, the extraction socket remains as it is. I try to do something. When I suspect something like that, I try to do curettage thoroughly to expose fresh bone. However, it didn't go well. The patient doesn't have osteoporosis, I was wondering what I needed to do. Immediate implant placement can be done. So we decided to place an implant, and if you look at here in the video, radiopaque mass is observed around that. There's no bone near that mass, hardly any bone. The axial view, after 4 months since extraction, it's not very well healed. I thought I could get initial stability from somewhere because it's quite far from the canal, and if I placed a long implant, that could have worked. But we had only 10 millimeter implants in stock. In the radiolucent line, it stays there. SS3 or SS2 type implants, that's what I prefer. And we decided to place it and submerge it. Last year, through this case discussion, I talked about the tip to get the stability using an osteotome. Just like nailing it, we can put pressure on the fixture. A curved osteotome is put on a cover screw and tap it about twice. It's a very simple way to get the stability. The implant stability has become very good these days. I thought I could get stability with that, and it was submerged. It was mobile. The value was 0. And after 3 months, in the second surgery, you can see the bone filled up. As it was loaded, radiolucency disappeared almost all, and it's healed. When stability was not there, osseointegration can be achieved with a little bit of help, like under drilling or the technique that I introduced before. Osseointegration can be achieved. Dr. Kim Ki-Seong has prepared a similar case. Would you explain that, please? I was in trouble once at number 36 while I was placing an implant. That happened. I thought the bone quality was not really bad. On CT, actually, initial stability was obtained. I disconnected the mount, and while connecting the cover screw carelessly, it happened. The implant fell into the, so to speak, mandibular sinus. It fell while the connected cover screw was being tightened, so there was no way to retrieve it. I drilled into the cortical bone and lifted up. It had nothing to do with the mandibular canal. I tried to place one size bigger implant this time again, but it fell 3 or 4 millimeters below. It was submerged like this, and later prosthesis was delivered. At that moment, I was really nervous, and I called several colleagues to come and help me, but they couldn't come as it was in the evening. I courageously drilled into the cortical bone and lifted up. It was my first case to drop the implant in the mandible, and I became more careful afterwards. Now the bone quality is getting better. Most important factor for implant success is the initial stability. If you have good initial stability, the success rate of implant is getting better, and we can get very good initial stability. During diagnosis, we need to analyze the bone quality, taking CT image before we enter there. During surgery, we need to feel the bone quality. We also need to pay attention to the initial drilling in the cortical bone. During drilling, I take note of the bone quality in the bone that is taken out. and I decide whether I will do under drilling or regular drilling. This is a hot topic these days, which I have not used it. This is a hot item for osseo densification. I heard it has versatile functions. I believe it can change from D3 to D2. In this particular case, I don't think this will be of great help. One of the techniques that I use is that OSSTEM implant specification. There are many different lengths. The diameter increases in 0.5 millimeter increments. If you cannot get the initial stability, you could replace the implant with one size bigger. Number 17 and 27, 7 millimeter implants are placed. It was not intentional. Due to lack of initial stability, the size got bigger and eventually achieved the initial stability. In this case, this is not a routine technique, but you can do it this way. My favorite technique is the under drilling. In this case, 5.0 implant is my favorite for the posterior region. To place it, when I use the one guide, I use up to 3.5 millimeter drilling. So this is a 3-step under drilling. Without the guided surgery, placing a 5 millimeter implant into 3.5 millimeter drill hole is very challenging. There will be resistance at the entry point. While placing the implant, the handle will tremble, hard to get the stability. The problem can be resolved by using a guided surgery. So let me show you a video. Another tip that I use clinically is the implant surface. OSSTEM focuses on implant surface development. It evolved from SA to BA through CA and SOE. Still, some dentists stick to SA because it has been performing pretty well. I personally compare the surfaces BA or SOE and tested. BA and SOE also integrate much faster. With those implants, the secondary stability will happen faster. So ultimately, the total stability will go up faster, even though the initial stability was low. Let me show you how I use the techniques at number 47, the bone quality of which is not very good, as Professor Yang showed. I thought the initial stability would be poor. I used the guided surgery and under drilling of several steps, and I achieved initial stability. I'll show you the video. Only with this one guided surgery, the initial stability can be obtained. Initial drilling, the first drill. Secondly, 3.5 unguided drill is used for the osteotome. The mouth opening is limited, so it was a little bit difficult. 3.5 drilling, filling the bone quality. 5 millimeter implant is placed, skipping 3 steps. Without the guide, we cannot go in there smoothly. The guide enables very stable drilling. Therefore, we can go in there, gaining initial stability at very slow speed at 15 RPM. Under drilling and using the guide is a very good idea for gaining the initial stability. CT image. In general, implants can be placed deeper. In this case, if you go below the cortical bone, you may lose the initial stability. In the maxilla, many different techniques can be used. When the cortical bone is very thin, while you place the implant, it can drop into the sinus. Dr. Cho Young-seok came to my clinic and did the surgery. The bone thickness was 1 or 2 millimeters. Using that thickness, TS implant was placed. Very sensitively, the cortical bone is used. For the placement, I use SS implants rather than this technique. TS implant uses submerged protocol. If you cannot use the cortical bone, it can drop into the sinus. And SS doesn't have the problem. SS implant can gain initial stability from the cortical bone. So using the SS implant is another good way to achieve initial stability. Summary: underdrilling is my most favorite one, and I am equipped with the various implant fixtures. I use one guide system to place all the implants. Guide system helps me to gain initial stability, and very meticulous and careful placement is important. RPM should be set low. Carefully, meticulously, you need to place the implant for initial stability. Progressive loading in terms of prosthetics is a good way to place an implant in the area where bone quality is poor. Thank you very much for the explanation. Dr. Son Young-hui, would you like to give us the explanation? When the bone quality is poor, I have some techniques to address. This overlaps a lot with what Dr. Kim Ki-Seong said. Yeah, everybody follows similar protocol. I do undersized drilling. That's the first choice. Next, I submerge the fixture and wait for a long time, whatever the initial stability is. Those two are mostly used. When I select the fixture, shape and surface treatment will make difference. As Dr. Kim Ki-Seong said, osteodensification. I have not tried it yet, but there is a method to stimulate the bone formation and consolidation. Submerge and wait. Underdrilling is always included to get at least the minimal initial stability. 54-year-old female patient who was referred to me. 10 months after extraction, bone did not grow. Number 36 and number 37 are missing. The panorama X-ray shows 10 months after extraction. CT, the basal bone cannot be used because it is too close to the canal. I want to go along the oblique line, drill into there. It is opened. Number 6 is not a problem, but number 7, how many drilling have I done, do you think? Not at all. I did the drilling, as you can see. It looks like bone. Maybe not. It disappeared as I touch it, so I try to not to touch it. 3.5. No, sorry. I drilled up to 4.0 and TS3 6 millimeter is placed without bone graft. I thought there's no need for the bone graft. I made it bleed and it is covered with the membrane. I wanted to see what would happen. As Dr. Kim Ki-Seong said, after undersized drilling, RPM during placement should be lowered when initial stability is expected to be poor. Some dentists use 50 RPM, so do I, as I am very impatient. But in this case, you should use lower than 20 RPM. And the surgery is concluded As you can see, it is just put in with a stability of 0. Post-op 1 month, 3 months, 5 months, second surgery is done. 7 months, prosthesis was delivered. As you can see, over time, distal bone trabecular pattern is regenerated. Prosthesis, bone is grown surrounding the implants. 17 months, panorama X-ray. Compared to the time of placement, you can see the difference. The best solution when the initial stability is poor, you just wait as it is. Time will solve the problem. Second, selection of fixtures. Tapered body is better than the straight body, which has poor stability. Initial stability. Pitch depth is an influencing factor, but among the geometries, it has the least impact. Deep threads may be considered to have a good initial stability. That is not the case. And of course, the rough surface and chemically modified surface is better than RBM or smooth surface in terms of the outcome. So when you expect the initial stability will not be very good, you need to consider these. Next, osteodensification. Dr. Kim Ki-Seong talked about Densabur. I have used it. Osteodensification. Before we used submerged osteotomy, we have already used it. We use initial drilling and expanding it when the bone quality is not very good in maxilla. This is my case. Long time ago, number 16 is extracted and bone was not growing, so it is opened. Only initial drilling is done using the osteotome. PAOSFE is done here. It is continuously expanded. An implant is placed and submerged. Using this technique, we have already used osteodensification method. Second surgery, post-op 7 months. Compared to other densification methods, this requires more time. The outcome is more or less the same. So that's how it goes. In this patient, I used the Densabur, which is a very trendy, hot topic these days. I was wondering what is so marvelous about that. I bought and used it, and it's very expensive. 74-year-old female patient. The bridge over 13, 14, and 17, there was pain and foul odor. At number 15, the bone is not very good. This is a typical old people's trabecular bone pattern. I expected initial stability would be poor. The bridge is cut at 5, 7 is extracted, it is opened. We can tell by just looking at the cortical bone. Densabur is used. In this case, the Densabur can be used in all of the company's products. This is for DS2 and DS3, Densabur protocol. It can be used for OSSTEM products. Densabur, as you know, is used in the reverse direction to place an implant. When you do the drilling, it looks like this. Just visually, you can't tell the difference. It's submerged. When you use the Densabur, you need to be careful about one thing. For example, if you are to place 10 millimeter implant and you drill 10 millimeters, you can encounter a disaster. Implant is usually placed 1 millimeter below the bone, but if you drill 10 millimeters with a denser burr and to place 10 millimeter implant, if the bone quality is poor, the side walls are weak, it may rebound, losing the initial stability. Therefore, as I said, you need to drill 2 millimeters more to place a fixture to avoid a disaster. I'm not sure if it facilitates the osteodensification. I need to use it more. I looked for the information. I think it's right. It can make the bone quality dense, but I heard that if you use the osteotome, trabecular pattern would be broken, slowing the secondary stability. So that's what I heard. What do you think? Between 2005 and 2008, papers came out on that subject. I've used the denser burr. I believe it must be satisfying the needs of many dentists because it is very popular, but I'm not sure its effect on sinus or osteodensification. I'm not sure. Using the osteotome, as Dr. Son showed, it quickens the process using the drill. In terms of the simplification of the procedure, it can be useful. But as you said, trabecular pattern is broken. To get the stability, does it help healing? It's controversial. According to the company's papers, the problem with the papers is that they use the heart bone. The number of cases for D4 bone is not many, so we need to wait and watch. The speakers in overseas congresses, they showed dramatic results, but in my hands, when I use it, I get some good results, but as Dr. Son said, sometimes it gets me confused. I go like, what's happening? I believe we need the learning curve. If we can utilize it properly, it'll be good. I have a question for both of you. I do the under drilling. Dr. Son and Dr. Kim also do the under drilling. One of you use the template, one guide, and one of you don't. Dr. Son always uses the guide, but I don't use the one guide, but I have a tip to go in there. I can place an implant which is 2 sizes bigger, and you did that. Is there any other tip to get the initial stability other than one guide? I'm actively supporting the use of one guide. When you think initial stability would be hard to get, as you have experienced, sometimes we rotate it just a little bit more and then disaster occurs. At least if you use the one guide, such risk can be eliminated. Personally, when initial stability is not expected to be good, I encourage the use of the one guide. Other than under drilling, I have my own know-how in placing the implant. On the CT image, you know where bone is more, so during implant placement, I try to engage implant toward the bony site. That's my tip. I didn't show you, but sometimes I don't really place an implant, but put the implant into the jaw and wait. If there is no mobility and no problem in the adjacent tooth, TS3 implants that I placed get osseointegrated. That happens. The reason why I asked the question is, as Dr. Kim Ki-Seong said, SS3 implants are used by me a lot, and I do under drilling, and I get the stability from the design of the implant as well. TS or US implants, there's no structure above the bone, but SS implants have flared suprastructure above the bone. If you use the structure when there's no cortical bone, in my case, there was no such bone. What Dr. Son said is that he pushes the implant towards where bone is. If there's 1 or 2 millimeter cortical bone, I believe SS implant can work really well. In that case, as Dr. Kim Ki-Seong said, we can get initial stability sufficiently from there if we don't drop the implant into the maxillary sinus. If there is 0.5 or 1 millimeter cortical bone, we can get the stability from there. That was a very good point, and I totally agree with that. Should I go on? Personally, I don't really trust the white papers from manufacturers. We need to screen them. Regarding this device, I cannot give you a definite statement. I'm giving it a try, but there are other ways to do the same function. Isn't it expensive? Yes, it is. Can we buy just one single item? No. You don't have to use this. There are other tools available. Compaction and densification can be achieved with osteotome or other special devices. Post-op 3 months, so the time is shortened. Prosthesis is delivered and it is closed. Other ways, RHBMP2 can be used where the initial stability is expected to be poor. Here, hydrogel is used, and as a result of the study, it is not clear here. It was done on mini pigs. C is good, which uses RHBMP2. When it is used, like in C, the result is the best. A, nothing is used. So this way we can reduce the stability dip. I've not used it, but this is a study paper on the subject. Do you insert this after the bone is prepared? Do you insert BMP before you place the implant? Defect is created intentionally. Initial stability will be gained from the bottom, and on the crestal part, the implant does not come in contact with the bone. BMP loaded composite is inserted there. Of course, you will have good results where BMP2 is used to grow bone faster where the bone quality is poor. This paper is written by a Korean orthopedist, and he used dental implants to write the paper, which was surprising. So thank you very much. After placing an implant in a poor bone area, initial stability and osseointegration can be occurred at the beginning, but when the long-term prognosis is not very good, what do you do? Dr. Kim Ki-Seong touched upon the progressive loading The loading time is very important. For the bone to be consolidated, it needs to be loaded. In other words, a force should be applied, and we need to determine the timing for that. It depends on the bone. Simply put, you need to have some clinical experience to decide the timing. However, doing fast doesn't help. Everything, the basic foundation for everything is taking time. If you take time, we can minimize the failures. Time is critical. The problem is, if we can shorten the time, it will be good to increase the patient satisfaction. I measure ISQ to determine the timing. If we determine the bone quality just based on photo or panorama X-ray, it is not easy. So regularly ISQ values are measured, whether the values are increasing to determine the loading time. There has been great strides in the development of implant surfaces, shortening the loading time. Within 2 to 3 months, ISQ values are increased even in the sinus. So we need to use some objective measurements to determine that. So the force would be applied after prosthesis is delivered. It can be okay initially, but I'm worried about the long-term prognosis. What do you think? It differs from individual to individual, but we need to think about the bite force that can break the osseointegration. Before that, the implant cannot withstand the 35 Newton centimeter when it is tightened. After that, appropriate bite force will contribute to the consolidation of bone as long as it's not excessive force. However, if it is excessive force, osseointegration can be broken. Therefore, as he said, we need to have some experience to determine that. These days, I don't worry about osteointegration. When implant is fractured, it is hard to retrieve it because it is too solidly integrated. Let's go back to the case under discussion. Based on what we have discussed, how would you conclude? As I said before, using a guide under drilling and using a good implant surface. Under drilling, wide fixture, submerge, and wait. That's what I recommend. I agree to all of those. In my case or the case under discussion, outer surface, the cortical bone is there, but there's no bone inside. As I said before, it needs to be submerged, absolutely. In my case, after 3 months, second surgery was done, the bone filled up. If you use reliable fixtures, no problem will be encountered, osseointegration can be achieved. In this case discussion, we talked about how to gain initial stability where bone quality is poor. Thank you very much. The dentist who sent us this case, I would like to thank our panelists for the good advices. This concludes the discussion session. Regrettably, this is my last time to work as an MC in the case discussion. For the last 10 months, we have dealt with the various clinical difficulties, and I learned a lot from the discussion of the panelists. I'll try to improve myself as a clinician. From now, I will watch this program as an audience. Thank you very much. I'm Dr. Jung Young-eun, MC of the discussion. Thank you very much. It has already been 10 months. It seems like this brilliant studio is going to be dimmed a little bit. She was a brilliant MC, and it helped a lot to have enjoyable discussion. We'll have another opportunity to be together. We'll let her go. I worked as an MC and I learned a lot from our masters, and sometimes away from the camera, I ask the questions to the panelists. And I really learned a lot. I hope we have another opportunity to play the role of an MC like this. Thank you very much.